So welcome back to my house. Going to try to cover the next chapter, chapter 25, the sensory system of the eye and ear. We're going to go over chapter 25 and 26 today. I'm hoping this finds you all well, and I'm hoping these recordings are helping. In addition, we're going to be meeting weekly online on WebEx to discuss the chapters and any questions that you might have. So almost think of this as reverse classroom. Now, I actually do this down in some of the high schools downstate, where unfortunately the children don't get quite the attention at home. So what they do is they send recorded lectures. They just have the parents play the lecture for the child. That way the parents don't have a whole lot of work. All they have to do is just make sure the child watches the video, the classroom portion, and they focus on doing the homework and the study portion in the classroom. It's kind of a reverse cycle. We're going to be kind of doing that now, and let's see how that works for us moving forward. So let's don't forget once again to look at your objectives as you're going through, write them out, watch this video, but also read the chapter. And as you read the chapter, write down the answers to those objectives and make sure you know those and study those. Okay? There's only 9 for this chapter, so it should be pretty straightforward. All right, here they are. And moving right along. The anatomy of the eye, the structure of the eye. The eye is a spherical shaped object, if you would, almost ball-like. It's about 2 to 3 centimeters in diameter. It has the sclera and the cornea, which is the opaque white covering that covers the posterior 5/6 of the eyeball. And the transparent cornea is what covers this film that covers the entire eye itself for protection. Now, the cornea is going to cover the anterior portion of the eye, and that's, as I said before, that's for the protection. And that's where you get things like corneal abrasions and those types. The choroid is a part of the middle layer of the eyeball. It is a highly vascular area. The ciliary body is the middle layer of the eyeball as you take the eyeball and peel the eyeball back. Now, what I recommend is go online, Google anatomy of the eye, and watch a video on anatomy of the eye. And I've got a web link there that shows you, but also Khan Academy has really good anatomy videos in my opinion. So you should join Khan Academy and look at their videos. The optic nerve comes into the back of the eye and into the eye itself, where the optic disc then comes in. When you look into the eye, that's what you visualize. What you'll do is you'll look into the eye. Typically, when you look into the eye with a ophthalmoscope, you're going to focus in on a blood vessel, and then you're going to track that blood vessel all the way down from the periphery of the eyeball, and it'll track you all the way down to the optic nerve. And that's where you'll be able to see the optic nerve. Of course, the outside, you got your eyelids, eyelashes and all that. And of course, don't forget all the muscles that attach to the eye, so it enables you to move the eye from side to side, up to down. And that's why we take the eye through the various stages. And when you're doing a physical exam, you have the patient hold still, and you have them go up, down, left, right, okay? And then I do cross, back, cross, down, nope, my bad, cross, up, okay, and cross, down. So all you're doing is you're going to church, Amine, Padre, blah, blah, right? And then you're like, hey, with the holy water. You guys have all seen the priests do that. They're like taking holy water and they're like, whack, splash, and whack, splash. right? And then they're blessing you, right? So that's what you do. You move them through that, and that gets you to make sure that you can see that they can move their eye in all the various vectors that they're able to move their eye in when you're doing your physical exam. And so that's an important aspect. All right. So you understand the structural protection, but think about it. You absently blink how often? Well, why do you blink so much? Well, you blink so much to put moisture and lubricant over your eye. That also, by lubricating your eye, keeping your eye nice and moist so your eye doesn't dry out, it also protects your eye. As your eyelid sweeps over, eyelashes move any dust particles out of the way to prevent anything from getting into your eye. And the eyelid itself runs over and makes sure nothing is in your eye, keeps it nice and lubricated and moist. All right, so being able to blink and produce tears is an important aspect of keeping your eye itself protected. Your fields of vision. Now, we talked about the fields of vision before. You typically have like 6 fields of vision. By the way I do it with the 4, I test 8 fields of vision. But if you have that, you can move into those areas. You're good to go. You usually have up, down, left, right, both eyes. Boom. That makes it 6. Now, I will say though that your eyes are binocular in nature. They're offset. The optic nerves actually cross, as you can see in the video, the slide that you have right now. But more importantly, before you look at that slide, that's on page 573, look at the figure on page 572. And that's going to give you the complete structure and anatomy of the eye and how the eye is composed. So know that the eye, what it does, and the structures. The eye is protected first and foremost by the bony prominence that is around the eyeball. The other structures that protect the eye, as I said earlier, are the eyelashes, the eyelids. The lubricant helps protect, and that's through sebaceous glands and secretions. Blinking is one of the #1 ways to keep your eye moist and lubricated, and also to protect the eye. So that enzyme that is in your tears also is an antibacterial, so it helps to destroy any bacteria. And I just saw in the news the other day that pink eye, they're now assuming pink eye to be one of the early signs and symptoms of this COVID-19. So keep an eye out, okay? People forget. They think that all too often viruses can only invade the body through the respiratory tract. Well, while it's true that we typically inhale and we receive by touching our face, we forget that our eyes is a portal of entry. And it's one of the ways that we can actually introduce a virus into our body. So just be cognizant of that and keep an eye out. I hope things are going well in your community. We had our first death in our community within the last 24 hours. Even though we don't have many cases, I think we only have 4 or 5 down here in Iosco County. We have already had one negative outcome. So I pray that you guys are keeping your community safe and you're doing the right thing by staying home, staying inside, and watching my obviously exciting videos. Yes. Okay, now the eye itself, when we examine the eye, we want to check the internal pressure of the eye. We want to, back in the old days, you used to actually take a weight and put a weight on the eye, and you would have to numb the eye, and the weight would then push up on the scale, and you could actually read the number. And they came out with the new devices which can measure interocular pressure. And it's a little puff of air, and some of you have probably had that. And now they have even newer devices that they just take and they touch it against your eye, and it digitally will tell you what your interocular pressure is. And of course, we want to keep the interocular pressure below the normal range. Can anyone tell me what the normal range of interocular pressure is? Well, we'll be covering that in more detail tomorrow, or I should say in the next lecture. I don't know, you might want to watch both videos today. I shouldn't say tomorrow, but it's usually less than 20 is the key. So, moving on, the muscles of the eye, the extrinsic skeletal muscles and intrinsic smooth muscles, such as the ciliary body, things that are the skeletal muscles. So these are the things that you have control over, and then you have the things that you don't have any control over, such as you don't control whether or not your pupil dilates, period. The refractory light does that. So there are both extrinsic and intrinsic muscles that are working within the autonomic system, and some of these things will have control over, some of them you won't. Now, if you look at the table 25-1 on page 573, it'll show you the actual eye muscle in coordination with the controlling cranial nerve. You do need to know, because that way when you're moving the eyes through their motion, you know which cranial nerve. Now typically it's, for the most part you can see, it's going to be the cranial nerve number 3, oculomotor. But when you get to the lateral rectus, moves eye laterally away from the midline, moves eye laterally away from the midline, moves eye laterally away from the midline, okay? That is the abducens, and the superior oblique that depresses eye and turns it laterally from the midline. That depresses the eye and turns it laterally from the midline. That is the trochlear. So you just need to keep an eye on those minor. For the most part, it's ocular motor when it comes to moving the eye itself. All right, now what starts to happen as you get old? Well, unfortunately, like the rest of your body, not much good occurs. Your eyes become more sunken. You develop an opaque ring around the cornea. This can sometimes result in fatty globules that are deposited, and result in this arcus senilis. The cornea itself will flatten and become irregular. This can lead to astigmatisms, or make any astigmatisms worse, which can lead to visual disturbances. The sclera itself becomes less white and more yellowish in nature. The ability of the iris to dilate actually decreases. This can cause difficulty going from bright to darkened areas, which can impact night vision. You get huge changes after the age of 40 because the lens itself changes over time, and as the lens no longer responds, it becomes harder. Cataracts may form, but also you develop what's known as presbyopia. Presbyopia is basically eyes over 40 years of age, and you no longer have the ability to adjust, so you can't focus on things that are close, and you have to. That's why when you see people holding or reading a menu or a magazine out here, out at arm's length, way out there, it's because they have presbyopia and they're having a hard time. And it makes reading difficult, so therefore you end up with reading glasses. Also, you can start to develop a droopy eyelids. You can get the inflammation, repeated inflammation of the eye, keratitis, uh, and ptosis. And these are all common things that occur with the eye as the eye ages. Additional things that cause eyes to degrade is things like diabetes. You end up with like macular degeneration, diabetic macular degeneration, which can occur in the eye. Glaucoma, and we'll be going over glaucoma in more detail in later classes. Smoking, age-related macular degeneration occurs, and of course cataracts can occur with aging, and you may need various surgical procedures. There are things you can do for the eye. There's actually vitamins you can take. There's vitamin packs as you get older that are made specifically for the eye to help with the eye. So nutrition is an important aspect of eye health. But one of the biggest aspects is prevention of injury. When I was an instructor at the Special Warfare Center in school, one of the courses I taught was patrolling. And we'd go out on patrol, and on night maneuvers back then, it was inevitable we'd get a lot of soldiers. You try to walk through the woods at night, and you end up getting a stick in your eye. And it didn't take me long to figure out that the students who wore glasses didn't get sticks in their eye. So I, being the lazy medic I was, I ordered safety glasses for everybody, racquetball glasses, and just said, hey, everybody needs to wear these at night. They're just clear racquetball glasses. And we went from having, I couldn't remember how many eye injuries, I mean, it would be 1 or 2 a night, to having none. And it was such a simple thing to do. Well, then down the road, now everyone gets issued safety glasses in the Army with various lenses. And they also found out that in combat, if wearing glasses and say an explosion occurs and shrapnel, regardless of the type glass you're wearing, you stand a chance of saving your eye just by having glasses on. This is why I wear glasses. These are reading glasses. These are not prescription. I mean, they are prescription, but they're not required. I can take my glasses off. Like, granted, I not look goofy, but because you guys get used to seeing me with glasses. But at the end of the day, I can read the screen just fine from this distance. Causes of the eye disorder. Oh, diabetes mellitus and hypertension. It's just that when I put the glasses on, obviously you think of me as more intellectual, but besides that, I primarily wear them for up close reading, and number 2, they do serve as a line of protection for my eyes and therefore prevent eye injury. So that's something you should think about when we're working. Okay, education. Our goals is to promote healthy vision and prevent the accidental injury to the eye. That's why things like right now, you hear a lot of people talking about face shields being utilized, and not just masks, because it is, as I've said before, the eyes are a portal of entry to the body. We want to prevent eye strain. Now, in today's society, I'm amazed, man. This, right? One of these bad boys, you guys all have these. Well, guess what? So do my grandchildren. And oh my gosh, I am amazed now that they're staying with me for an extended period of time during this COVID crisis. Wow, they spend a lot of time on devices. If any of you have children, you probably feel the same way. So I've started a new campaign of we're going to go outside. We're doing home teaching. Well, Grandpa has become the gym teacher. I'm like, and the science teacher and the history teacher. So what I do is we actually started watching a series of movies. We started with the American Revolution with the Patriot. We watched that, and then we moved on to the Civil War with Glory, and we're going to watch Tonight's movie is going to be Dances with Wolves, which is going to cover Western expansion, and I'm taking them through the complete realm of U.S. history through movie night. And during the day, we got the trampoline outside, and I put up a basketball net. I got one of those and put that up. And I take them to the range, of course. I do believe in staying active with bow and arrow and outdoor shooting. So we all went shooting the other day. And hopefully I'll get out there shooting the shotguns today. Gotta go kill some clays, you know. Anyhow, I'm hoping you all are getting outdoors as well, too. And getting off those devices, because they can cause serious eye strain over time. And that can lead to headaches and lead to other issues. You know, a lot of people, oh my God, my neck hurts. Well, you know, you get that whole tension headache. You need to relax. You need to not overwork the eye muscles. Think about good nutrition. Now's a good time to think about resetting. Maybe starting some exercise programs, maybe a nutrition program, and looking for the silver linings in this recent cloudy skies, and trying to find a way that we come out of this with some positive attributes in the end. Okay, so those are things that you can do. As I said before, here are some of the vitamins. Vitamin A, antioxidants. These are very helpful to eye health. Okay, we talked about before. One of the biggest things that cause complications of the eye is cosmetics. And truth be told, you really want to get rid of your eye makeup. And I think it's every 6 months you're supposed to have the makeup thrown out. Of course, an eye exam, annual eye exams, go a long way to making sure that you don't experience any complications, and also to catch any ailments early. Some of the danger signals or danger signs that you might look for is persistent redness of an eye, any pain or discomfort in your eye, visual disturbances. It's amazing how long people will let these things go for before coming in to be seen. You should not experience any pain or discomfort in your eyeball. That's not normal. Okay? You shouldn't be experiencing double vision or halos or color flashes or persistent floaties. Those are all signs and symptoms that there's something going on. For young children, crossing of the eyes is a huge indicator. Any type of growth on the eye or eyelid itself, discharge, cross, tearing, these all need to be looked at by a healthcare provider in a timely manner. Do not wait. As I said before, diabetes and hypertension, those are both comorbidity to eye disorders or diseases that can occur. So you want to maintain control of the diabetes. You want to keep their glycemic index in a tolerable range. You want to keep their hypertension under control. This means that they need to be under proper medical care, taking the appropriate medications, and also seeing an eye and having eye exams on a regular basis. It's not just about seeing an optometrist. And optometrists they're great people, and if that's all you can see, but you should see an ophthalmologist. All right. Don't forget cultural considerations when it comes to the eye. And numerous studies have shown that Latinos are more prone for open angle glaucoma. And we'll be going over, as I said before, open angle glaucoma in later class. You do want to always have proper diagnostic examinations. Make sure that the eye is screened. The tonal pen is often used in such screenings, and the tonal pen is designed to, well, first and foremost, it's there to make sure that your interocular pressure isn't too high or elevated. Other diagnostic tests that they can perform is obviously the visual acuity is one of the most important ones. 20/20 being what's considered normal vision. You can have the near vision test. You can also look into the eye with a slit lamp, and you can inspect the entire eye itself internally using a ophthalmoscope. So you can look at the various tests on table 25-2 on page 576 and page 577. So, and as I said, I got the various type of examinations and of course nursing management. Using an ophthalmoscope, I said already, right? You can go through, visualize the inside of the eye. And most of you already had this done to you, or you've seen this being done. So, abnormalities of the eyelid. You can have various abnormalities of the eyelid, and it can be entropin, ectropin, or the eyelid rolls out or the eyelid rolls in, and then ptosis where the eyelid itself just droops. Nursing diagnoses. For the abnormalities of the eyelid, look at table 25-3 on page 580. It'll tell you that the entropin is the inversion of the eyelid. The ectropin is rolling out, the outward turning of the eyelid. All right. Now, you got your different nursing diagnoses and nursing interventions that you can do for eye injuries. Obviously, risk of injury related to decreased visual field, fear of blindness, impaired home maintenance, sensory perception alteration. Those are all your common nursing diagnoses. Goals: promote optimal vision, prevent infection, prevent injury, cope with any visual loss, and knowledge and self-care. You guys already should have been taught how to apply medications. If not, on page 581, box 25-1 will completely cover the installation of eye drops and eye ointment. All right, read both the drops and the ointment to fully understand how to place both in. All right, remember these people have visual impairments, not hearing impairments. You don't need to yell at someone who has a trouble with visual issues. Okay, they're not helpless, but they do need assistance, and sometimes just arranging things appropriately in their environment can go a long way with aiding them to be self-governing. All right, assisting with the visual impaired and how to use your CNA. You guys are already aware of this. Moving on to hearing loss and structures of the ear. Okay, you have different types of hearing loss. So first off, let's look at the structure of the ear. You have the external part of the ear, okay, the pinna, which gathers all the sound waves. It focuses it into your ear canal, if you would, and then those vibrations then hit up against your tympanic membrane inside your ear. As they move down the external ear canal, the tympanic membrane vibrates. It vibrates against the malleus, the incus, right, stirrup, and then those vibrations are then transferred, right, through to the semicircular canal, to the vestibular nerve, the cochlear nerve, and finally the auditory. And as such, hearing in balance is then maintained. So the ear does more than just hearing. It also helps maintain your balance, your equilibrium. And that's an important aspect of the ear itself. And you can see the outer area, the pinea. Okay, where the air, you have the pinea where sound waves are collected, sent into the external ear canal. Sound waves then vibrate up against the tympanic membrane. Tympanic membrane then vibrate. The vibrations are felt much like a needle on a old record player by the malleus, the incus, okay, the hammer, anvil, and stirrup, right? Those vibrations are transferred to the semicircular canal where the nerves, the vestibular nerve, the cochlear nerve, okay, and of course the auditory nerve, then collect the vibrations and move it on. And that movement and vibrations is then sensed, and your body then interprets them as sound and balance for coordination. Because that's why if you get an ear infection, your balance gets thrown off. Yeah. So it prevents entry of foreign objects by the way it's designed, because it's a closed system with a tympanic membrane. That's why if you get a hole, a puncture through the tympanic membrane, that's bad. It hurts. You get an ear infection. All right. And in order, you have therefore an internal pressure from a internal part of your ear and an external pressure. And that pressure has to be equalized. Otherwise, boom, your eardrums will rupture. And ruptured eardrums can't transmit vibration and can't transmit impulses. So you want to take care of your ears. You want to keep your ears clean. But you also don't want to put any foreign objects into your ears. Never put anything into your ear bigger than your elbow, right? You guys remember that commercial? Yeah. Well, a lot of people don't listen to it, and they put, they stuff things like Q-tips in their ears, and they end up injuring their tympanic membrane. Especially little kids. You'd be surprised what little kids will jam in their ear. Also, you'd be surprised what can crawl in your ear. When I was a paramedic in Detroit, I went in on a call, and this lady, in the middle of the night, woke up crazy, beating her head against the wall, just slamming, literally slamming, and just screaming. Well, a cockroach had crawled on her pillow and crawled into her ear and crawled in, so it was still alive, crawling, but it couldn't turn around because there wasn't enough room. So it just kept crawling and crawling, and it was butting up against her tympanic membrane, just scraping and scratching. Could you imagine having an insect, a live insect inside your ear? Just, and yeah, so I don't blame her for going crazy. We finally flushed it out, and she was immediately better. But meanwhile, she was hard to get a hold of. So things that can cause hearing loss. Well, if you get too much wax buildup, that cerumen buildup, it starts to harden. And I've seen people go in where we go in, doctors or providers, or I've gone in with a loop. It's a little wire loop, and you hook on and you just drag the wax out, and then you take and you flush the ear. Obviously, that's the best way to clean your ear, is to irrigate the external canal. And urine actually makes a decent kit on how to clean your ears. As you get older, the tympanic membrane stiffens, so therefore it doesn't vibrate as much, and therefore you're going to have hearing loss. Of course, the cells themselves, receptor cells, decrease, and the nerve fibers decrease. So the vestibulocochlear nerve itself no longer responds as well. So therefore, as you get older, you lose your hearing, and you lose your balance. You're not as coordinated as you once was, agile and coordinated as you were in your youth. Yay! Lots of fun to getting old, huh? So what do you want to do? Well, you want to prevent hearing loss at first and foremost. So you want to treat any severe ear infections. I'm not going to lie, you're going to see ear infections more in young children because of the way the ear is designed. They haven't grown yet, and they're more prone to inner ear infections than adults. And as such, they get a lot of them. Now, consequently, if they get too many and they keep getting ruptured eardrums, that can lead to hearing loss. So if a child is prone, usually it's more than 3 ear infections within a year, then they're a candidate to have tubes placed in their ears, and that can reduce the number of ear infections. And some of you might have had that done as when you were children. All right. Now you can have conductive hearing loss or sensorial hearing loss. That's noise-induced hearing impairment. So there are 2 types, and this is covered over on page 584. There are 2 types of hearing loss related to problem in the ear, sensorial and conductive. Approximately 80% of hearing loss is caused by disorder of the hearing nerve, sensorial loss. Conductive hearing loss is caused by a problem transmitting sound impulses through the auditory canal in the tympanic membrane. So conductive is the air is not being conducted in. There's something blocking, like cerumen sometimes, or the tympanic membrane is hardened and stiffened, or the bones in the middle ear have deteriorated. Where sensorial hearing loss would be more of a hereditary, congenital drug toxicity. Best way is just to look on box 25-2 on the bottom right-hand corner of page 584, and it will tell you conductive hearing loss versus sensorial hearing loss, and it'll go over in complete detail the types of hearing loss. If you think, okay, conductive, you think, airwaves being conducted, and something blocking it, blocking the vibrations, stopping the conduction of the vibrations, that would be conductive hearing loss. All right. As I said before, ototoxicity, this would be more sensorial hearing loss. Drugs that cause ototoxicity, there's a lot of them, and you need to be familiar with them, especially in young adults. Young adults are very sensitive, and they can have impaired hearing for the rest of their life due to, all too often, our young you, the student nurse in the clinical environment, catches the provider ordering an adult dose of antibiotics for a pediatric patient. I can't tell you how many times you guys have caught that, and you probably have saved numerous children from hearing loss or potential ototoxicity. So that's why it's so important for you to know exactly how much, because giving a child an adult dose of antibiotics, would it kill them? Most likely not, but it surely has potential to kill their auditory nerve and cause ototoxicity. So you guys need to be aware of that and just keep with that. Noises that are actually can damage your hearing. If you look on page 585, table 25-5, it talks about things and what the typical decibel is. And for example, a truck traffic, a noisy appliance, a shop tool, a lawnmower. If you're cutting grass for over 8 hours, you can damage your ears just from cutting grass. If you cut grass for over 8 hours straight. But as you get to the higher, like just shooting a gun without hearing protection, one time, and you can have permanent hearing loss. Well, so there are things that you don't even need to have. Once you get above 100 decibels, things like chainsaws, headphones. Kids listen to their, talking about devices, a lot of kids have these Bluetooth headphones in now. And, I'm sitting across the room and I can hear my grandson's headphones. And I'm like, that's too loud if you can hear it if I can hear it from across the room. So what kind of hearing damage could that be causing? So you just have to think about decibel levels, and that's a great table on page 585 for you to look at. All right, so I already talked about knowing the toxic effect of autotoxic drugs. Important. Listen, you're not going to be looking inside someone's ear and looking at their eardrum, just like you're not going to be looking inside someone's eye and looking at their optic disc. You're not going to look at the tympanic membrane. Those are more invasive tests for providers and not so much for nurses. What you will do, though, is you will check and test general hearing and general hearing loss. You will do a whisper test. So, or, just something light to see if they can hear that. Okay, you might whisper a number in their ear and whisper another number in their other ear and have them repeat it back to you. You will be conducting a Romberg to see if their balance is off. And if so, could it be caused by any type of inner ear infection or labyrinthitis or vertigo? Okay, you will be looking for hearing impairments, and then you're going to help to figure out, is this conductive hearing impairment or sensorial hearing impairment? Now that you might use a tuning fork to determine in your physical assessment, and utilize a tuning fork to see if it's they can't hear from the earwaves, or then you put it against the mastoid process here, and then if they can still hear it, then it's being conducted. It's so if they can't, this is sensorial. And if it's the airwaves, then it's conductive. Dizziness, vertigo, tinnitus. Tinnitus is just ringing in the ears. All right, already told you how to flush the ears to clean. And then rehabilitation. Some patients might need to be taught sign language over time because their hearing loss might be permanent. They might end up with a cochlear implant or hearing aids. Hearing aids is a huge aid for geriatric patients. And of course, some patients learn to read lips or sign language. One of the issues with hearing aids is they're battery operated, so knowing how to replace the batteries is going to be an important aspect of your nursing care, believe it or not. So, what else? When caring for the hearing impaired, make sure you face them when you speak to them, so that they can. A lot of times, they can kind of read your lips, and that helps. Speak slower, enunciate your words. Don't shout or yell. All right, well, this kind of finishes up. I'm sorry about the choppy ending of that last slide. Obviously, you're going to have to make serious modifications for people with hearing loss and visual loss. What you do for them is going to depend on, how severe their impairment is. And we're going to go over some of those impairments next in the next chapter of disorders of the eyes and ears in chapter 26. So take care, and I'll see you in the next chapter.